Thanks to the chair, Professor Amita Agrawal, for being so punctual to be in that time always and having this opportunity to present this CGI today on this topic of the changing paradigm of kidney disease in patients with diabetic mellitus. We all, as Madam has pointed out, many of us have diabetes, many will develop diabetes, and those who develop diabetes, 30 to 40% patients would have the diabetic kidney disease. So it is very important to understand how the dynamics of the diabetic kidney disease has changed over the years. We have purposely chosen this topic because this would be of interest for everyone. And this will be the case-based discussion so that we can have some learning points out of this CGR presentation. So you can look at this picture. This is the global pictures. In 2017, almost 425 million people have diabetes. And it is projected to increase by 629 million population would have diabetes in 2045. And out of them, 40% would have some degree of renal involvement. And it has rightly pointed out in the early 2000s that diabetic kidney disease might be a medical catastrophe of worldwide dimension. How this dynamics has changed? Have look on this first slide of this presentation, natural history of diabetic nephropathy. The concept, this was based on the 30 years observational study by Mogansons, who have given a chronology of development of the staging of the diabetic kidney disease. At that point of the time, diabetic kidney disease term was not coined. This has recently been coined because the spectrum was changing of the diabetic kidney disease. So initially it was diabetic nephropathy. What we can see when you look at the chronology last part, at the second stage, some patients would have hypertension. At third stage, some patients would have macronuria, then overt nephropathy, and then end-stage kidney disease by the end of the 30 years. But this chronology is not true now. What we can see, there are three different spectrum of the diabetic kidney disease now, which is well recognized. One is the typical diabetic kidney disease, so-called diabetic nephropathy or proteinuria diabetic kidney disease, where the duration fits into diabetic duration of more than 10 years. Patient would have the hypertension, patient would have the retinopathy, patient would have the albuminuria, no RBC, bland sediment, no biopsies needed, clinical diagnosis. But non-diabetic kidney disease is increasing with the aging, increase of the malignancy, increased incidence of infection in diabetes, non-diabetic kidney disease increase. With some therapeutic acidency, ACE inhibitor, angiotensin II receptor blockers, the spectrum of this proteinuria diabetic kidney disease have changed. So now you have the clinical suspicion first of the non-diabetic kidney disease, which comes when the duration of the diabetes does not fit. There is absence of the other macrovascular complications like the diabetic retinopathy. You would have the only some degree of proteinuria or no proteinuria. You have the macroscopic hematuria, and that spectrum, macroscopic hematuria, RBC fast, that spectrum is changing. What you can see, why this happened, that is more important. In early 90s, what we have shown you in the era of the 80s when the classical diabetic nephropathic changes were happening. Here in 90s, ACE inhibitor has been introduced. In 2000s, ARB has been introduced into management as antiproteinuric agents. And the present era, present decade is of florigines or flogins, canagliflozin, empagliflozin, or dapagliflozins. And that have changed the spectrum. So what happened? The classical progressions from one stage to other stage have changed, and many patients of the diabetic kidney disease, proteinuria diabetic kidney disease becomes non-proteinuria, and incidence of the non-proteinuria diabetic kidney disease went up to 30 to 40%. 30 to 40% of all patients would have non-proteinuria diabetic kidney disease. Recently, there are 3 randomized controlled trials. How important it is? Randomized controlled trials published all in NEJM in 2019, 20, and 22. One on canagliflozins, other one dapagliflozin, the third one was empagliflozins. The result was so impressive, people have started using in non-proteolytic diabetic kidney disease. In IMPA kidney study, the bigger, you can see here the bigger slides here. IMPA kidney, more than 2,000 patients are non-alcoholic diabetic kidney. And they have tried, and there was impressive results of slowing down the progression of the kidney disease. Instead of falling of the GFR, which was the classical teaching in our MBBS or MD 10 to 12 ml per year will be loss of the GFR in typical diabetic kidney disease that reduced down to 2 to 5 ml per year. So that was the changing. And here, in our, what we have seen here, many patients of the diabetes, which were mimicking like non-diabetic kidney disease, mimicking like the diabetic kidney disease used to come to us. We have large cohort of the patients where what we have seen, what happened with the therapeutic hesitancy when use of the ACE inhibitor, angiotensin receptor blockers, protein, mineralocorticoid receptor blockers, how this have changed the spectrum. So today we have selected cases which can reflect that how we suspect a patient having the diabetes of the longer duration can have a non-diabetic kidney disease. We can pick it up and we can treat and we can get the result. So still, how to use the newer agents? This is the diagram. It is like a blind man and elephant of the CKD prevention and promotions. How this is blind? Nobody knows whether the DAPA should be given before ARB, because most of the trials have shown ARB should be given first and then use dapagliflozin or any flozins. So that kind of things was emerging. So with the learning objectives, what we have defined from the department, we will have some cases of the typical form of proteolytic diabetic kidney disease, atypical form of the non-proteolytic diabetic kidney disease, non-diabetic kidney disease, how you suspect, and how the therapeutic residency evolved over the years. Thank you, ladies and gentlemen. Dr. Shaurya will come to present the first case of the kidney disease. Thank you.
Good morning. Starting with the first case of the morning. This was a case of a 42-year-old male who had diabetes since 15 years, for which he was taking metformin and glimepiride with poor control, hypertension of 8 years, for which he was on calcium channel blockers, had presented to us with bilateral pedal edema off and on for 3 months, associated with decreased appetite. At examination at our center, he was detected to have a BMI of 25.8 kg per meter square, BP uncontrolled, pallor, and pedal edema. He had end organ damage in the form of proliferative diabetic retinopathy, autonomic neuropathy, distal symmetric sensory polyneuropathy, and peripheral arterial disease. His review of creatinine values revealed that he had a fall in GFR of 16 ml per minute over last 3 months, which fell into a category of rapidly falling GFR on a patient who was not on ACE inhibitor. His investigations at our center revealed severe anemia, moderate renal failure, hypoalbuminemia, nephrotic range proteinuria with nil active sediments. His workup for anemia revealed normocytic normochromic anemia, normal iron profile, stool local blood being negative. For his proteinuric illness, anti-plaquenil was negative, workup for myeloma was negative, workup for amyloid was negative. His ultrasound and renal Doppler was normal, and 2D echo was suggestive of mild concentric engage. So what do we do when a patient of diabetes presents to us with renal dysfunction? We look how long the diabetes has been lasting since when the renal dysfunction sets in. Our patient had diabetes for 15 years. He was overweight and a strong family history. He had hypertension, which came after diabetes, suggestive of hypertension being a complication of diabetes. And he had albuminuria and proteinuria, which was there of 3 months duration with no previous reports of micro or macroalbuminuria in the past. His GFR was rapidly declining. His end organ damage suggested a diabetic retinopathy, neuropathy, and peripheral arterial disease. And based on these end organ damages and the renal dysfunction, he likely had diabetic retinopathy, but there were atypical features which will be discussed later. Other lab parameters revealed that he had disproportionate anemia, as only 1/10 of the patient with this level of chronic kidney disease have hemoglobin less than 10. He had severe anemia with a hemoglobin of 6.1. His ancillary investigations was within normal limits. When we summarize the duration of diabetes, the end organ damage, the onset of hypertension after diabetes, the proteinuric nature of illness suggested a diabetic kidney disease. However, the disproportionate anemia and the rapidly falling GFR intrigued us to get a kidney biopsy done, keeping in features of possibility of a non-diabetic kidney. The biopsy shows on the left side is a H&E stain. At the center, we see a viable glomerulus with an increased mesangial matrix, and at 1 o'clock position, there is a globally sclerosed glomerulus. Similarly, on past stain, at 6 o'clock position on the right side of your screen is a blood vessel hyalinosis, which is seen, and at the center, there's a glomerulus showing increased mesangial matrix. This is the classical KW nodule, which on higher power shows the palisading of the nucleus to the periphery of the nodules and the central matrix accumulation. Findings of diabetes were seen on electron microscopy with a thickened glomerular basement membrane and increased mesangial matrix. Overall, the biopsy was suggestive of diabetic nephropathy class 3. How did we manage the case? We managed it with lifestyle modifications and have been following up this patient since 1 year, and the BMI had reduced from 25.8 to 23.4 kg per meter square. For his sugars, linagliptin was added along with SGLT2 inhibitors, and his target HbA1c was kept below 7. For antihypertensive, apart from the calcium channel blockers, ACE inhibitors were also added. He is planned for starting of non-steroidal mineralocorticoid receptor antagonist on further follow-up. He has been on follow-up since last 1 year. As we know, we expect a fall in GFR of around 5 ml per minute on a patient, 5 ml in a patient in 1 year of diabetes nephropathy. In our patient, as we see, the GFR was initially 34, it improved and has been stable around 40 ml per minute. Similarly, creatinine has also shown improving trend and is stable at around 2. The hemoglobin is improving with around hemoglobin of 10, with the patient being on iron supplements and erythropoietin stimulating agents. Things to note is that there can be a rapid fall in GFR in diabetic kidneys, particularly with poor glycemic control and BP control. RAS inhibitors, SGLT2 inhibitors, and non-steroidal mineralocorticoid receptor antagonists have been proven to alter the trajectory of diabetic kidney disease. To discuss the next case, I'll invite Dr. Yashendu to the dais, please.
Good morning, everyone. So coming to the next case of the morning, we have 43-year male who is known case of type 2 diabetes for 15 years, which is fairly well controlled on oral hypoglycemic agents. He is hypertensive for past 8 years, which is uncontrolled. He presented to us in the month of August 2021 with complaints of easy fatigability and decreased appetite for 3 months. On examination, his pulse was 80 beats per minute, blood pressure was on the higher side, and pallor was noted. There was no evidence of diabetic retinopathy. Sensory polyneuropathy was present. However, there was no evidence of macrovascular involvement in form of cerebrovascular, peripheral vascular, or cardiovascular disease. His laboratory examination showed anemia with hemoglobin of 9.3, moderate renal failure with creatinine of 3.6, with relatively well-preserved albumin, and HbA1c of 5.4, indicating well-controlled sugar. His urine examination showed 1+ albumin with presence of active sediments, and 24-hour urine quantification showed 0.5 gram protein excretion per day. In view of active urinary sediments, his immunological workup was done, which was negative. His ultrasound showed normal kidneys with normal ecotexture, and 2D echo showed mild synthetic LVH. In view of absence of diabetic retinopathy, presence of microscopic hematuria, and in view of background non-edematous and non-proteinuric illness, he was planned for biopsy with possible differentials being non-albuminuric diabetic kidney disease, chronic interstitial nephritis, and IgA nephropathy. As we could see, the first slide shows a normal glomeruli with presence of arteriosclerosis. The second slide shows presence of marked to moderate interstitial fibrosis with presence of tubular atrophy in the form of wrinkling of tubular basement membrane and loss of ecotexture. After ruling out drugs, infections, and other autoimmune etiology, a diagnosis of diabetic kidney disease with predominant vascular and tubular interstitial pathology was made, which is also called as atypical DKD or non-albuminuric diabetic kidney disease. I would like to re-emphasize the fact that the presence of non-proteinuria in a diabetic patient need not always be a non-diabetic kidney disease. It could still be a non-proteinuric variant of diabetic kidney disease. In a typical diabetic kidney disease, the patient goes through a phase of microalbuminuria, followed by macroalbuminuria, followed by a phase of decline in GFR and leading to end-stage kidney disease. However, there is a paradigm shift in this presentation, which was reported as early as 2003 by Wikipedia study, where they found that nearly half of the patients who had reduced GFR did not had preceding albuminuria, and 40% of the patient never developed albuminuria during the study. There are various evidences to support the same. We have Indian evidence as well, which shows that 26.5% of the patients with diabetic kidney disease did not have proteinuria. Even in our center, we have experienced that nearly one-third of the patients who visits us are non-proteinuric or low proteinuric, and amongst those who have undergone biopsy, nearly 31% of the patient had this phenotype. As compared to a typical diabetic kidney disease, in a atypical or non-albino diabetic kidney disease, the decline in GFR is not preceded by increase in protein excretion, or these patients never develop protein excretion during the course of the disease. These patients have low GFR with low albumin excretion ratio. These patients have macroangiopathy as compared to microangiopathy, which is seen in a typical diabetic kidney disease. These patients have no correlation with microvascular damage like retinopathy, and on biopsy, it is the tubular and vascular damage, which is the predominant findings. Female are more predisposed to this entity, and as seen in our patient, there is no correlation with HbA1c. It is the recurrent episodes of AKI of varying nature, whether ischemic, drugs, or obstructive, which leads to its transition to CKD. Studies have also shown that these patients may be genetically predisposed to this entity. Despite sharing conventional risk factors like obesity, metabolic syndrome, and dyslipidemia with typical diabetic kidney disease, because of early and good glycemic control nowadays and increased use of anti-proteinuric agents, we are seeing a rise of this entity. On pathology, we find fewer glomerular lesions. There is disproportionately severe tubulointerstitial lesions, and the presence of this disproportionately advanced tubulointerstitial fibrosis with vasculopathy with minor or no diabetic glomerulopathy is the hallmark of this disease. As compared to a typical diabetic kidney disease, these patients have slower decline in eGFR. Even the all-cause mortality in such patients are found to be low. Indian study was consistent with this, where they found that these patients tend to be older and they have a slower decline in GFR. As shown in the bar diagram, the patient who had over proteinuria had much more decline in GFR as compared to those who didn't have. Our patient was managed with dietary and lifestyle changes along with adequate blood pressure, glycemic control, control of lipids, and use of renoprotective medications like RAS blockade and SGLT2 inhibitors. Our patient was followed up and it was found that at baseline, when the patient had a creatinine of 3.6, during the follow-up, there was stabilization of renal function and the creatinine was 2.9 at 24 months, which corresponded to a GFR of 27 as compared to baseline of 21. So before concluding, I would again re-emphasize that the presence of non-proteinuric disease in a diabetic patient need not always be a non-diabetic kidney disease. There is a paradigm shift in the presentation and there is growing incidence of the same. Presence of vasculopathy and tubulointerstitial changes are the predominant findings on the biopsy, and choice of antihypertensives like RAS blockade, use of SGLT2 inhibitors as the anti-diabetic agent can modify the outcome of the patients. Now, after seeing the typical and atypical variants of diabetic kidney disease, I would like to call upon Dr. Mugdha to take us through the non-diabetic kidney disease presentation in a diabetic patient. Thank you.
Here is the next case. This is a 53-year-old male with diabetes since 20 years, poorly controlled, and hypertension since 2 years. He had bilateral non-proliferative diabetic retinopathy as a microvascular complication. He had noticed bilateral pedal edema for 12 months, and he has checked his creatinine, which was 2.1 in the month of August. In September 2023, he presented to us with easy fatigability, oliguria, and low-grade fever for 1 week. On evaluation, we found that his creatinine had jumped from 2.1 to 8 within a span of 1 month. His total leukocyte count was 11,500 with 16% eosinophils. His urine routine microscopy showed proteinuria of 2+, 1 to 2 WBC casts, and 3 to 4 RBCs. His 24-hour urine protein was 2.1. In view of acute rise in creatinine, low-grade fever, we ruled out tropical infection. The workup was negative. His urine culture was sterile and immunological workup was negative. His kidney biopsy showed normal findings. Kidney ultrasound showed normal findings. So our differential diagnosis at this point was acute and chronic kidney disease in the background of type 2 diabetes and hypertension. Etiologic diagnosis we considered were acute tubular injury secondary to infection or drug-induced acute interstitial nephritis. The Asia-Pacific Society of Nephrology Clinical Practice Guidelines on Diabetic Kidney Disease gives certain red flags for when to consider kidney biopsy in a diabetic patient with renal dysfunction. Our patient had presence of rapidly declining GFR from 33 ml per minute to 8 ml per minute within a span of 1 month, presence of active urine sediment containing red cells and cellular casts, and presence of systemic signs and symptoms. Hence, we went ahead with a kidney biopsy. This is a HNE stained kidney biopsy slide showing a viable glomerulus with increased mesangial matrix. On the tubulointerstitial section, the tubules show leukocyte infiltrates, a WBC cast, and the interstitium shows dense inflammatory infiltration. Hence, our diagnosis at this point was diabetic nephropathy class 2B with acute interstitial nephritis. On further evaluation, we evaluated for the cause of acute interstitial nephritis. He was taking tablet metformin, linagliptin, metoprolol, and cilnidipine for his diabetes and hypertension. On further probing, he revealed that he had started taking a herbal medication for 2 weeks in desperation to control his blood sugars and deranged creatinine. In view of metabolic acidosis and volume overload, he was supported by renal replacement therapy. He received 3 sessions of hemodialysis. All his medications were reviewed and the alternative medications were stopped. His urine output started doubling after 1 week and creatinine started improving, as you can see in this graph. When he had presented to us, his creatinine was 8. When we stopped the offending agent, his creatinine started gradually declining, and as of November 10th, his creatinine was 1.5 within a span of 2 months. According to our experience of non-diabetic kidney disease among diabetics, acute kidney injury with a baseline CKD was a common indication for kidney biopsy in almost 21.1% patients. Acute kidney injury without a baseline CKD was an indication in 6.8% patients. In the kidney biopsy findings of diabetic patients presenting with non-diabetic kidney disease lesions on their kidney biopsy, almost 26% patients had acute interstitial nephritis as their finding. Among diabetic patients who had non-diabetic kidney disease and diabetic kidney disease lesions on their kidney biopsy, still acute interstitial nephritis was the most common biopsy finding in almost 51% patients. As compared to another study from South India, where indication for kidney biopsy was unexplained renal failure in 33.4% patients, even there, the acute interstitial nephritis was the most common kidney biopsy finding in 47.2% patients. So learning points from this topic were, it is difficult to identify the culprit drug causing acute interstitial nephritis, especially in diabetics with history of polypharmacy and frequent use of over-the-counter and alternative drugs. Identification and management of the offending agent itself stabilizes the renal function. Now I call upon Dr. Piyush to discuss the next presentation of non-diabetic kidney disease.
Good morning. I will be presenting a case of 60-year-old female who is hypertensive for 15 years and diabetic for last 4 years, which is controlled on 2 oral hypoglycemic agents. She presented to us with chief complaints of facial puffiness and bilateral ankle swelling, which was insidious in onset and gradually progressive in nature. She also complains of frothiness of urine. However, there was no history of hematuria or oliguria. On clinical examination, she had grade 2 of fetal edema and blood pressure of 150 by 100 millimeters of mercury. Rest of the systemic examination was unremarkable. She has no evidence of microvascular complications of diabetes, including no evidence of diabetic retinopathy. On evaluation, she had normal renal functions with creatinine of 0.9 milligrams per deciliter. She had hypoalbuminemia. She had dyslipidemia. Urine routine microscopy showed albumin of 3+ without any activity in sediments. So the quantification of 24-hour protein was done, which revealed 7 grams of proteinuria per day. For this patient, we kept the syndromic diagnosis of adult onset nephrotic syndrome, and for the differentials, we kept the possibility of diabetic kidney disease, since it is the most common cause of secondary nephrotic syndrome in diabetic individuals. However, the short duration of diabetes mellitus, the onset of hypertension 10 years prior to the onset of diabetes, and the absence of diabetic retinopathy made us think about the possibility of non-diabetic kidney disease. In non-diabetic kidney disease, we kept the first differential of membranous nephropathy because it's the most common primary glomerular cause of nephrotic syndrome in adults with or without diabetes. And the rest differentials we kept as minimal chest disease and focal segmental glomerulosclerosis because these are the common etiologies of nephrotic syndrome in this age group. So we did the further workup and it revealed that she had an optimal glycemic control with HbA1c of 6.6%, and she had a raised anti-plateau titers, which was 38.7. So for this patient, to confirm our diagnosis, we performed the kidney biopsy. Kidney biopsy revealed as compared with the normal glomerulus on the left column, where the glomerular basement membrane are thin and delicate. In our patient, we found that the GBM was diffusely thickened and the capillary loops were stiff, and there were no evidence of endocapillary or cellular proliferation. This suggested the diagnosis of membranous nephropathy. We further did special stains, and on silver stain, it was shown that there were focal argyrophilic spikes, which are due to the extension of basement membrane material between the immune complex deposits in the subepithelial region, which has consistent with the diagnosis of membranous nephropathy. Further, we did tissue immunohistochemistry for the phospholipase A2 receptor, which showed the diffuse and granular positivity along the glomerular basement membrane, which is the characteristic of the membranous nephropathy. We further did the electron microscopy, which showed subepithelial electron disc deposits, uh, which has the final diagnosis of membranous nephropathy without any changes of diabetic kidney diseases was made. Now coming to the challenges of treating a patient with membranous nephropathy and coexisting with diabetes, clinically diabetic nephropathy can mimic membranous nephropathy as both of diseases present as proteinuric illnesses. And pathologically as well, both are characterized by glomerular basement membrane thickening, and in early stages, both of the diseases can be indistinguishable. However, identification of novel autoantigens and antibodies against them with good sensitivity and specificity for the diagnosis of membranous nephropathy has become a paradigm shift in the management of membranous nephropathy. Several autoantigens have been identified for the diagnosis of membranous nephropathy, the most common being phospholipase A2 receptor, which is a transmembrane receptor found in the glomerular basement membrane, and it accounts for around 80% of the cases with the primary membranous nephropathy. Other autoantigens include thrombospondin 7A, exostosin 1, exostosin 2, NEL1, and semaphorin 3B. As far as the therapeutic challenges are concerned, this is our center experience of treating idiopathic membranous nephropathy in patients with diabetes mellitus. The patients with membranous nephropathy are conventionally treated with cycles of methylprednisolone and cyclophosphamide, the regimen popularly known as modified Ponticelli regimen. The response rate to treatment of membranous nephropathy with conventional immunosuppression in individuals without diabetes were around 80% of remission. However, in our study, we found that patients who had coexisting diabetes, they responded poorly, and only 18% of patients have achieved remission, and that too at a higher risk of treatment-related morbidities in form of worsening of glycemic control, high increased incidence of infections and cytopenias. We managed our patients with conservative care, including optimal glycemic and hypertension control, including ARBs, SGLT2 inhibitors, statins, and diuretics. In view of heavy proteinuria, we have given her rituximab infusion. Our patient fortunately responded well in form of resolution of pediledema, and her proteinuria declined from 7 gram of baseline to 1.7 grams. That is more than 80% decline from the baseline value over a follow-up period of 6 months. She had stable renal functions throughout the course, and serum albumin has also improved to 3.8 grams. So the learning point from this case is that in a diabetic individuals, every proteinuric illness disease may not be related to diabetic kidney disease itself, especially patients who have rapidly increasing proteinuria, and in the absence of end organ damage, primary glomerular disease should always be suspected. I would like to call upon Dr. Kritika to discuss the next case.
Taking forth the discussion, he is another 63-year-old male who's a diagnosed case of diabetes for last 20 years, hypertension for last 15 years, which was poorly controlled. He presented to SGPGI with chief complaints of low backache for 3 years, easy fatigability for 3 months, and swelling in both lower limbs for 3 months. On general physical examination, there was presence of failure, pedal edema, and blood pressure was 140 by 100 millimeters of mercury. On fundus examination, there was proliferative type of diabetic retinopathy, and systemic examination was positive for neurological deficit of distal symmetrical sensory polyneuropathy. On laboratory evaluation, he had a baseline report in May 2022, which had normal hemoglobin, normal renal function with poorly controlled blood sugars. In September 22, he was found to have anemia, moderate renal failure with poor controlled blood sugars and HbA1c of 10.8. He presented to SGPGI in October 22, where there was persistence of anemia, worsening of renal function with creatinine of 6.9, with presence of hypoalbuminemia. On urine routine examination, there was presence of 3+ proteinuria with active sediments in terms of RBCs, 10 to 15 high power field. 24-hour urine protein quantification was suggestive of 4.8 gram of proteinuria, and ultrasound was essentially normal. We went ahead with further investigation. In view of rapid progressive renal failure, we did an immunological workup, which was all negative. Keeping in mind the age of the patient and preceding history of low backache, we did a myeloma workup, which was positive for kappa free light chain restriction. with kappa lambda ratio of 23.4. However, our patient was having long-standing history of diabetes mellitus with presence of diabetic retinopathy. Possibility of NDKD was kept higher in view of rapid fall in EGFR, disproportionate anemia, and microscopic hematuria. So we made a syndromic diagnosis of rapid progressive renal failure with underlying diabetes and hypertension, and a pathological diagnosis differentials for monoclonal immunoglobulin deposition disease, cast nephropathy, and to rule out underlying diabetic kidney disease. We went ahead with renal biopsy. This is a normal HND stain, normal glomeruli on HND stain. As we can see here, there is mesangial expansion with nodular glomerulosclerosis, which is PAS positive. Since these lesions are also seen in diabetic kidney disease, we did a methanamine silver stain, which was negative, making a diagnosis of immunoglobulin deposition disease. To further confirm the diagnosis, we did a direct immunofluorescence, which was suggestive of kappa restriction, with 3+ along the mesangium and tubular basement membrane. Electron microscopy was also done, which was suggestive of subendothelial granular deposits. To confirm the diagnosis of myeloma, we did a bone marrow aspirate and imprint smear findings, which was suggestive of cellular marrow with trilineage hematopoiesis with predominance of plasma cells. For quantification and immunohistochemistry, CD138 stains were used, which quantified more than 10% plasma cells, making a final diagnosis of multiple myeloma with monoclonal immunoglobulin deposition disease with underlying diabetes mellitus and hypertension. Based on this, patient was started on 6 cycles of cyclophosphamide, bortezomib, and dexamethasone. Since patient had advanced renal failure, he was started on renal replacement therapy. He received total 6 cycles of Cybody, and his renal functions gradually stabilized. His urine output improved to 1400 milliliters per day, and he became dialysis independent. His last follow-up was in October 23, where his creatinine has stabilized to 4.3 milligram per DL, and he continues to be dialysis independent. So in terms of renal parameters, he had partial remission. For hematological, we followed the kappa lambda ratio, which showed progressive decline, and he had a very good partial remission on bortezomib and lenalidomide maintenance therapy. So myeloma and diabetes, whether it's just a mere coincidence or share a causal relationship. In phase 3 APEX trial, it was observed that 18% of the patients who had recurred on treatment with myeloma had underlying diabetes mellitus. There is also increased risk of developing myeloma, developing type 2 diabetes in the myeloma patients. Diabetes is a condition of immunosuppression, chronic inflammation, and lymphocyte dysfunction. It leads to interleukin dysregulation, which further promotes the growth and survival of tumor cells, which might lead to development of multiple myeloma. It's also been observed that 6 to 24% of patients with multiple myeloma develop diabetes over the course of treatment. So the challenges that we face in treating these myeloma patients with underlying diabetes, there is increased risk of developing renal insufficiency, increased risk of worsening of retinopathy and peripheral neuropathy, and poor glycemic control because of ongoing corticosteroid therapy and chemotherapy. Discussing about the long-term outcomes, it was observed that patients with myeloma with underlying diabetes had an overall inferior renal and patient outcomes as compared to the non-diabetic patients. So the learning point in this case was coexistence of myeloma and diabetes is not just an association by chance, and there is a high incidence of monoclonal gammopathy among the diabetics. We should keep a high clinical suspicion of myeloma in patients with diabetes who present with unexplained renal failure and disproportionate anemia. And despite the therapeutic challenges, the overall treatment modifies the renal outcomes. For the next case scenario, I would like to call Dr. Apur for further discussion.
Good morning, everyone. I am going to present my case scenario. As 50-year-old male, non-diabetic for last 4 years, diagnosed hypertension for last 6 months, having non-healing foot ulcer in left plantar region for last 2 months. Patient noticed facial puffiness and ankle swelling for last 1 month. Patient also had 1 episode of cola-colored urine 1 month back. On examination, patient has blood pressures on half sides. Reports reveals that patient has high TLC count with serum creatinine of 5.3 milligram per DL, with serum hypoalbuminemia with HbA1c of 8.5%, which showed poor glycemic control. His old reports revealed that he had baseline creatinine of 1.1 in March 23. With prior to admission, he has acute rise of creatinine from 2.4 to 5.3 in the 3 days of duration. Urine analysis showed active sediments. 24-hour urine protein was collected and reported as 6.1 gram per day. Further evaluation revealed the patient had low C3 complement levels. So on the basis of history and
reports, laboratory reports, we made a syndromic diagnosis of acute kidney disease with pathological differentials of infection-related glomerulonephritis or sepsis-related acute tubular necrosis. With best possible etiological source of infection was infected chronic diabetic foot ulcer. So for this, we went ahead with renal biopsy, which on histopathology showed increase in mesangial cellularity with lobular accentuation and neutrophilic infiltration with endothelial cell proliferation and obliteration of capillary loops, which were suggestive of infection-related glomerulonephritis. Electron microscopy revealed thickened GBM, which was glomerular basement membrane, which was suggestive of underlying diabetic kidney disease with subepithelial hump, which was suggestive of infection-related glomerulonephritis. So our final diagnosis was infection-related glomerulonephritis with underlying diabetic kidney disease. So patient pus managed as his pus culture showed growth of methicillin-resistant Staph aureus, for which appropriate IV antibiotics were given. Patient was managed supportively and his blood sugars and blood pressures were optimized. Patients were showed improving outcome as his serum creatinine was settled to 0.89 at the 3-month OPD follow with his 24-hour quantification of protein was showed settled to 0.97 milligram gram per day. So similar patients of infection-related glomerulonephritis were studied at our center over the 4 years of time duration, out of which 32% were diabetic. In treatment, approximately 65% patients were managed by controlling source of infection. 30% patients were given low-dose steroid, and 5% patients were given other immunosuppression in view of crescenting on renal biopsy. The long-term renal outcome of infection-related glomerulonephritis at our center showed poorer outcome in diabetics as compared to non-diabetics. The rule of immunosuppression for ESRD-free renal survival at 4 years follow-up showed non-significant differences in both cohorts. So the learning point from my case is that any acute rise in creatinine among diabetics with source of active infection, we must suspect infection-related glomerulonephritis, and the early diagnosis and control of infection will lead to better renal and patient outcome. Now I would like to invite Dr. Vamsi, Faculty of Nephrology, for share our center experiences.
Very good morning, everyone. I'll be sharing our experience of various kidney diseases in our center across the past 17 years among various patients with diabetes. So around 17 years from 2005 till 2022, 5,400 patients underwent biopsy. Of them, 580 were diabetics, implying that more than 10% of the patients who underwent biopsy were diabetics. And of them, 540 patients who had complete data were analyzed. In our analysis, we found that among the patients, rapidly increasing proteinuria was the most common indication for biopsy in our cohort, contributing to around 23%, followed by acute rise in creatinine with a baseline CKD in 21%, rapid decline in GFR in 19%, and active urinary sediments in 19%. Other less common indications for biopsy are absence of diabetic retinopathy, AKI without underlying CKD, and shorter duration of diabetes. So these are all the conventional indications in which biopsy is indicated among diabetic patients. But despite these conventional indications, we found that 30% of the patients did not have any non-diabetic kidney disease pathology, and the changes were related to only diabetes. And 70% of the patients had non-diabetic kidney disease. Of them, 20% had both changes of non-diabetic as well as diabetic kidney disease pathologies, and 50% had pure NDKD. Among the various types of NDKD that we have analyzed, we found that the most common cause of NDKD in our cohort is acute interstitial nephritis, contributing to around 1/3 of the patients, and followed by infection-related glomerulonephritis in 14%, membranous nephropathy in 10%, IgA nephropathy in 10%. Other less common causes are FSGS, pauciimmune crescentic GN, membranous GN, and even lupus nephritis and cast nephropathy in some cases. We also found that among the patients who had both NDKD and DKD, more than 50% of the patients had acute interstitial nephritis as the NDKD pathology. We analyzed the factors that are associated with presence of NDKD on biopsy, and we found that on multivariate analysis, the duration of diabetes less than 5 years, absence of coronary artery disease, absence of diabetic retinopathy, presence of oliguria or decreased urine output at presentation, acute rise in creatinine, and low serum C3 level were significantly associated with presence of NDKD in biopsy. We went one step forward and we tried to develop a prediction model because, as we have seen, nearly 30% of the patients who underwent biopsy did not have any non-diabetic kidney disease pathology. So we tried to develop a prediction model in which, using the beta coefficient as strength of association, we have given weightage to the each factor that came significant on multivariate analysis, and we developed a score. We analyzed the performance of the score, and we have seen that on internal validation within our cohort, the area under curve was 0.869, and at a cutoff of 5.5 or above, the sensitivity was 85.6%, and with a preserved specificity of 80%. We have done a multicentric external validation of this score as well, and we have found that the sensitivity is around 80%. So for this application of this score on a bedside day-to-day basis, we developed a mobile app for predicting the probability of non-diabetic kidney disease pre-biopsy. So these are the parameters that are to be selected in individual patient that will give a score. And based on that, we'll get a positive predictive value or a pre-test probability of presence of NDKD pre-biopsy. So this is the score that we have developed. We have to just select the parameters. We'll get a score. We'll get a pre-test probability. And based on that, weighing the risk and benefit of biopsy, we can decide on whether to go ahead with kidney biopsy in a given patient of diabetes or not. So we have compared the non-diabetic kidney disease among other studies also, and we found that the non-diabetic kidney disease percentage is similar, around 50 to 60%. Most common type of non-diabetic kidney disease is interstitial nephritis, or the second most common cause of NDKD. And factors associated with NDKD were also similar. So this is regarding the non-diabetic kidney disease. Coming to the non-proteinuric diabetic kidney disease, which is the current growing phenotype. In our experience, we found that 1/3 of the diabetic patients who either in our outpatient or inpatients are of non-proteinuric phenotype. And to this phenotype, whether the added advantage of SGLT2 inhibitor added to the RAS blockade therapy is advantageous or any beneficial or not, we have to see. And so far, there is no data across the world, and we looked into this aspect as well. We followed a cohort of 166 patients who are non-proteinuric diabetic kidney disease, and we followed them either on RAS blockade or SGLT2 inhibitor or a combination. Baseline GFR was around 47 to 53. And at 1 year, we found that patients on RAS blockade has an improvement in GFR of 4.2. In SGLT2 inhibitor, improvement in GFR was 9.5, although sample size was less. And on dual blockade, improvement in GFR was 7.6. So this data is yet to be published. At least in the preliminary analysis, we found that SGLT2 inhibitor alone or a combination therapy was superior to RAS blockade even in non-proteinuric phenotype of diabetic kidney disease. So to conclude, a change in phenotype of diabetic kidney disease has been noted over the past 3 decades. And hence there has been a change in nomenclature from diabetic nephropathy to diabetic kidney disease. A non-proteinuric illness in diabetes is not always a non-diabetic kidney disease. And likewise, a proteinuric illness in a diabetes is not always a diabetic kidney disease. Diabetic kidney disease still is a clinical diagnosis and biopsy is not required, but red flags for the presence of non-diabetic kidney disease should always be looked for. Identifying and treating the non-diabetic component will improve the renal and hence the patient outcomes. Glycemic control, control of blood pressure, and anti-proteinuric measures still remain the mainstay of treatment despite the therapeutic advances. And appropriate choice of antihypertensives, oral hypoglycemic agents like SGLT2 inhibitor, and novel non-steroidal mineralocorticoid antagonists like Findrinone among diabetics significantly retard the progression of chronic kidney disease. We would like to thank all the departments, particularly Department of Pathology, for their outstanding support and standing by our side in the care of kidney diseases.